a real honor and a pleasure to have Dr. Richard Packard from England with us. And he kindly agreed to talk to us today in this very important teaching session. And there is no better teacher. I have learned a lot from Richard on various aspects of cataracts, and he is the pioneer of phacoemulsification in the world, but particularly in Europe. And ESCRS, those who have not heard about it, European Society of Cataract and Refractive Surgery, is one of the 2 or 3 pillars since its inception. So it's really honor, Richard, to have you here. And if it's okay, please deliver your keynote address.
Well, good afternoon, ladies and gentlemen. Abe, thank you very much for your kind words. It's always a pleasure for me to be back in India. I've been here many times over the last 30 years and visited many cities in this country. What I'm going to talk to you about today, I do have some financial interest in that. I'm involved with a company called Excellens that makes a product which I will be discussing to some extent during the course of this talk. My subject is about the importance of getting capsulotomy and IOL centration on the visual axis. And this, of course, will give you best visual outcomes, as I'll demonstrate. And it's particularly important for you, those of you who put in premium lenses, because as we know, when you start to go off center, as I'll show you, things don't necessarily go the way you want them to. So why might we be concerned by the size, circularity, and particularly centration of the capsulotomy? If it's not round, it can lead to asymmetric contraction, IO decentration, as you can see here. On the right, we've got some early fibrous changes in the capsule, and this lens may well, over time, start to decenter. As you can see, the one in the middle has done, and certainly the one on the right. If the capsulotomy is too small, it can create difficulties with the surgery and also lead to later anterior capsular shrinkage, which you can see an extreme example here on the right. What we want to do with our capsulotomy is to shrink wrap the IOL with the capsule, because we know, as David Spalton has taught us many years ago, this will lessen PCO. And the important thing about the overlapping of the IOL edge is it should, if possible, be symmetrical. Not what's happening on the left here after 1 year, but what is happening on the right after 3 years. IOL centration on the visual axis and the stability particularly important for multifocal and toric lenses, I've said, and this will also give you some help with getting the effective lens position. If you look in the first and third Perkindy images, and if they're in a good position, this is what you want to see with toric and multifocal IOLs, but I'll also explain to you about a different way of approaching this issue. However, if you see something like this, in this situation, the capsulotomy has been centered not on the Purkinje reflex or anything else, but on the dilated pupil margin, and you can see that the edge of the capsulotomy is almost over the edge of this IOL. The ideal capsulotomy location is centration of the IOL optic, as I've said, because we want it symmetrically, as you can see here, and this is critical to reduce uncertainty in the effective lens position. And this will also give you uncertainty as to what your visual acuity outcomes will be. If you look at the OCTs here, what you want to see is you can see the lens on the human lens on the right and the IOL on the left. This is beautifully centered. This is going to give you the position that you want, and it will give you also a good indication as to what your ELP is going to be. And this is even more important than standard multifocal lenses. What I'm talking about here are the capsulotomy fixated lenses, like the Femtis and also like the bag and lens, because they are only centered by the capsulotomy, so you've got to get it in the right place. If you look at the effect of intraocular lens decentration on image quality, this is a study that was done with a custom model eye, and you can see what happens with these 3 lenses. As you move away from the ideal position of centration, the vision gets worse. Capsulotomy centration is not obvious because we've got a number of axes that we can deal with. There's the pupillary axis, the optical axis, and the visual axis. But of course, from our point of view and from the functional point of view of your patients, it is the visual axis which matters. But then there's other issues like angle gamma and angle kappa, which can interfere with what happens with your result. And the important one is to be the critical one, and this will give you your best visual functions. It's non-trivial, though, the centration, because the lens itself is asymmetrically in a 3D way. It means also that you can have intraoperative patient tilt, which can affect what happens with the capsulotomy. If you have asymmetric mydriasis, if you rely on the pupil, this is going to give you problems. And also, we want as much as possible to know what the resultant resting location of the eye will be, because this effectively is your effective lens position. We know that it is further exacerbated in hyperopic patients who have a large angle kappa. If you look on this schematic, you can see how all of these things vary. We can have the visual axis, the pupil center, the capsulotomy and IOL position, and they aren't necessarily lined up the way you'd want them to be. The mesopic pupil center on the visual axis, there is an average displacement nasally of about 0.3 of a millimeter, inferiorly about 0.1 of a millimeter, and the worst case, a 0.6 millimeter displacement, is seen particularly in hyperopic eyes. And this is important because an IOL biospheric decentration will limit your tolerance on the visual axis by only 0.5 millimeter. It's been shown that small decentrations are normal, but anything more than about 0.4 or 0.5 causes significant retinal damage, retinal image degradation. And this is particularly true if you're using what most of you are using, which is an aspheric intraocular lens, because they are much less tolerant of decentration than lenses that have a little bit of spherical aberration. This is a method of getting the centration with the capsulotomy. This was a paper that was written by Vance Thompson, who uses the Zepto, and he uses the final position of P1 and P4 relative to one another for fixation. Now, this is all very well, but it's actually quite difficult sometimes to actually line things up. So it's not necessarily easy that you get it in the position that you want. So I'm now going to describe for you another method of capsulotomy and ultimately IOL centration, which does not rely on patient fixation, which you need for your Purkinje images. And this is selective laser capsulotomy with a device called Capsulaser. What you're going to do here is turn on the aiming beam and then focus and finally center on an area in the middle of the capsule on this intumescent cataract and then remove it. The capsulotomy is created in less than 0.3 of a second. What we have noticed, however, is that there is this central area of the stained capsule which has enhanced staining. And we found that this is coincident with the coaxial Purkinje reflex. We call this the trypan blue capsular landmark. Right, let's make it move. It's present in over 98% of eyes. It's circular in geometry. Its size is 2 to 4 millimeters in diameter. In younger patients, it requires a little bit longer dye exposure to enhance the visibility. And as I said, it's observed to correlate with the coaxial Purkinje reflex and therefore IOL centration. This is how we create it. This dye that I'm using is not standard trypan blue. It is a microfiltered 0.4% solution of trypan blue. It has a higher higher specific gravity than aqueous, and therefore it settles onto the capsule. You leave it there for about 45 to 60 seconds and then wash it out thoroughly. And you'll see as it's washed out that the central area of enhanced staining becomes more obvious, particularly now that we're putting in the optically clear OVD. And you can see it nicely in the center there. If you want to compare this vision blue, capsule blue, with standard vision blue or and the generics, you'll see that there's a dramatic difference in the staining ability and the time that it takes to happen. Within 60 seconds, you get a very intense staining. You can see on the right here an example of staining with capsule blue relative to vision blue. And from the point of view of the laser, this is important. It also gives you a better view of the edge of the capsule when you're doing your getting your cataract out, but also when you're putting IOL in. We published last year a study into the intraoperative trypan blue central landmark for use in capsulotomy and capsulorhexis centration. And this was the first time this was shown in the literature. It was a study of 180 eyes, 3 arms with 60 eyes in each arm. The first arm had pupil centration for the capsulotomy. The second arm had the trypan central landmark used for centration. And finally, the third arm, coaxial Purkinje centration. Our endpoints were decentration measurement of the capsulotomy from IOL, and we also compared this with the IOL master reference data via Callisto Eye, and you'll see that in a moment. And we found, as I say, there was this wonderful correlation between the Purkinje reflex and the trypan blue central landmark. And if you look at this in terms of closeness, you can see here it is very close indeed. And of course, this is what we'd like to see, the capsulotomy like that above, and the lens beautifully centered with the capsulotomy edge on it below. As I say, group 1 was pupil-centered, and you can already start to see some of them are not as well centered as they might be. Group 2 and group 3 are beautifully centered. We can see this more obviously in these group 1 eyes, where the edge of the capsulotomy is approaching the edge of the IOL, and it might well mean that as time goes on and the capsule changes in its natural history, that this will flip over the edge and give you early PCO. And you can see that it's not particularly tightly bound about where you'd like it to be. Group 2, we can see there is very good symmetrical coverage, and similarly in group 3. And if you look at this in a Cochrane view, you'll see that there is a significant superiority for groups 2 and 3 relative to group 1. And if we look now with the Callisto, you can see this is emphasized even more, particularly when you remember that Callisto is based on the limbus rather than anything else. How did post-op vision compare? We found there was actually a significant difference here between those using the TC landmark and the Purkinje reflex compared with the pupil. And because there was a very small SD, it means that the uncorrected distance visual acuities were clustered very much around 6, 20/20 or logMAR 0. And this, of course, matters, particularly when you're using premium IOLs, because you want your patients to be happy. So in conclusion, capsulorhexis capsulotomy centration and diameter are critical for effective lens position, particularly with premium IOLs. This minimizes IOL tilt and early onset PCO. The circular trypan central landmark is present in over 98% of eyes, and it has been observed to correlate with coaxial Purkinje reflex and IOL centration. Our study concluded that centering on the coaxial Purkinje reflex, if you have a cooperative patient, and the TCL are equivalent and both superior to pupil centration. In mature white cataracts, a non-fixating patient or one that's been anesthetized so that they don't have control over their eye, this is almost certainly the best technique available. And centration on the TCL provides the most practical approach excuse me, for symmetric 360-degree capsulotomy coverage of the IOL. Visual axis is identified with the coaxial Purkinje, Zeiss Callisto, and trypan central landmark, and the IOL is centered on the visual axis. I'd just like to talk to you briefly about the ESCRS meeting in Copenhagen in September. Thank you for your attention. I hope you feel like coming to Europe to see us there.
Thank you, Richard. You brought out a very important point, but never emphasized enough how valuable is this centration, and we struggled. But what you are showing seems to be quite user-friendly and repetitive in its performance, it seems.
Well, I mean, in the longer version of the talk, there's also the use of this trypan blue with manual capsulotomies. Okay. And the result is the same. Okay. You still have that centered capsulotomy on the IOL because you've been able to use either the Purkinje reflex or, more easily, the trypan central landmark.
Okay. So new terminology, trypan, TCL, okay? Anything?
Yeah, just
you can come here.
So, I mean, this is really interesting, and the fact that it goes into the workflow, you don't have to go to a separate machine. As we understand it, integrates onto the operating microscope.
It does. It's a very small device. It sits underneath the microscope. You need a 200 millimeter optical lens, actual length, focal length. But the great thing about it is that once you've used the laser, it just slides away. It's on little rails and it disappears, so it doesn't interfere with your surgical space or with anything else in terms of the view that you have of your surgery.
So the only thing I wanted to ask is there any difference in the surgical technique after we've removed the capsule? Do we have to be careful of a fragile capsule or anything?
Quite the reverse. We did a study which was published on cadaver eyes that were paired. And we compared flax with manual, flax with capsulaser, and capsulaser with flax. And if you imagine that the manual capsulotomy, the capsulorhexis that you all do, was 100% in terms of stretchability, femto, 70%, capsulaser, 150%. It's significantly stronger. What's happening is that the laser is turning the type 4 collagen of the capsule, which is very well organized like this and symmetrical. It's turning it into the collagen doing this, so that it's completely different. And what happens when this takes place is it becomes much easier to stretch and much stronger.
Thank you.
Okay. So I think we expect next time a talk on a collagen. Is that what you're hinting at?
Yes.
We'll be prepared. Okay.